Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today we'll be discussing spinal tumors. They are thankfully not that common, but they can have devastating consequences. Treating them is a highly specialized field, and I'm grateful to have one of the real experts in this area on the show today. My guest is my colleague, Dr. Daniel Sciubba. Dr. Sciubba is the co-director of the Institute for Neurology and Neurosurgery at Northwell Health and chair of the Department of Neurosurgery at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Dan, welcome to Well Said.
Ira, thank you so much for having me. This is a delight.
Let's get started by having you just explain what a spinal tumor is and whether there's a way that you and other experts in the field kind of classify them or catalog them.
In short, tumors can happen anywhere in the body, and some tumors, just like they can arise from an organ like the liver or the kidney, can arise from the spine, the bony spine, or the spinal cord. More common than that, however, is the tumors that start somewhere else. So maybe there is a tumor that starts in the liver, and then it arises later on in the spine in the form of metastatic lesion. As a result, these are quite common because not only do we think about spine tumors from the spine, but we also have to think about all those other cancers that can jump from somewhere and end up in the spine, which is pretty common.
So I was not correct in my intro when I said that these are uncommon. I guess I was thinking of things that arise primarily from the spine or the spinal cord, but you've expanded our thinking to talk about things that land there from elsewhere. So how common are these then?
So the primary ones are very rare, and some of these really aggressive cancers are even more rare. So these rare sarcomas, as people hear that term. But in terms of the metastatic ones that come to the spine, just for a scale or for a reference, when we think about brain tumors, there are 10 times more spine tumors than brain tumors. We get a lot of attention, as we should, about brain tumors. But when we think about people maybe in this audience, they might have someone in their family or someone they know who has a history of a brain tumor. A lot of people will say, I had a history of a family member with a spine tumor. They're just that much more common. And when they present, they can be very devastating with paralysis or pain. And so these are things that when they do happen, people do notice them.
So if we focus for a moment on those that are, as you say, primary to the spine, meaning they're not a lesion from another tumor that's traveled to the spine, do we know what puts somebody at risk for developing a primary tumor of the bone in the spine or the spinal column itself?
No, and some of these lesions, as you rightly stated in the beginning, are uncommon, and as a result, we haven't had as much experience with them as, say, we've had with breast cancer or with prostate cancer. And so some of these tumors or these lesions are what we call superorphan diseases. So, for example, if you have a tumor, I think the number is, if it's 1 in 100,000 people, if it's that rare, I think that's the number, that's called an orphan disease. But if it's 1 in a million, that's called a superorphan disease. So some of these tumors are so rare that we call them superorphan disease. And then you say, hey, why did I get this? And the answer is, it's so rare we don't seem to have a clear understanding, whether it be genetic or environmental. A lot of work and a lot of my research over the years has looked at genetics of this and ways to treat these, because when these people have these cancers, they look for help, but they find that a lot of people scratch their heads not knowing what to do because of the rarity. So we yet don't know what causes these rare spine tumors to occur starting in the spine.
Sounds like, again, most of the tumors that end up in that part of the body are really other kinds of cancers that have just spread in an unfortunate way to the spinal cord or the spinal column.
That's correct. So when we think about the big group of cancers, lung cancer, renal, meaning from the kidney, breast, liver, prostate, the number one place that they jump to is places like the liver and the lungs, and one of the top three is the skeleton. And when you look at the skeleton, people getting tumors that go in the skeleton, the number one place in the skeleton that they go to is the spine. So this is a pretty common thing.
So Dan, let me just back up and ask a question that I think I may be responsible for misleading our listeners a little bit, because I may have misspoken and I used the word spinal column when I meant spinal cord. But why don't you just differentiate what those two things are anatomically?
So when we think about the spinal cord, we think about a very soft tissue that extends from the brain. It's basically brain tissue, and it goes all the way almost down to our lower back. And, of course, the nerves come off this, and this is the area that, of course, gives us the ability to have our brain affect all of our muscles and things like that. And that is a very soft tissue, and that is protected by basically a scaffolding or a shield in the form of bone that wraps around that, and those are the bones that form our bony spine, which is some people call the spine itself, or the bony spine, as opposed to the spinal cord, which lies inside of it.
Got it. Okay. So you mentioned before some of the symptoms that people who are afflicted with tumors that affect either the cord or the bony spine. Could you just run through what sorts of symptoms spine tumors might commonly cause?
So when we think about the spinal cord being the wire that connects our brain to our legs and our arms, affects our neurologic function, when there's a tumor in that wire, all those things can be affected. So patients can present with problems walking, problems with balance, problems with bowel and bladder function, pain, sensory loss. And so really people can have anything from the neck down, if you will, because the spinal cord begins at the base of the skull. So it can affect one's arms, one's legs. When one thinks about a tumor now outside the spinal cord, maybe in part of the bone, you have an issue where that really can cause severe, what we call mechanical pain, meaning that patients say, I can hardly move because I feel like I have a broken back because the bone has eaten away the bone, and as they stand up and load their torso on their lower back, they'll have a lot of pain. Now, if that tumor gets very big and somehow has gotten big without eroding the bone, the patient didn't present like that, it can act just like the spinal cord tumor, where if it presses on the spinal cord or invades in some way into the canal where the spinal cord lives, they can also present with weakness, numbness, and problems walking and such.
It sounds like there's a wide range of symptoms that people can present with, which I guess leads to a challenge in sorting out what's causing it. So what's the typical evaluation that a patient with a suspected tumor would undergo to sort this out?
The issue is both clinical, meaning that doctors have to see you or providers have to see you in person and talk to you about and examine your body and listen to you, just to understand the nature of what you're experiencing and the progression. As I always say to my patients, I say the trend of how you're doing dictates a lot of what we do. If you had a little achy back for the last 20 years, I'm less as concerned about that overall than someone who says, my back pain's getting worse every day this week and now my leg is feeling numb. Obviously, that last person is more urgent. The next thing we do is we look radiographically. We take pictures, and those can be in the form of X-rays or CAT scans or MRIs or even other scans to look at, for me as a surgeon, the anatomy and say, oh, it's actually it's shaped like a ball, or it's shaped like a peanut, or it's near this organ, or it's right near the skin, and we can do different things about it. And then the final thing is, if this is something that we think could be a cancer, we might do a biopsy, where we stick a needle into the mass, and before we do anything, whether it be radiation or surgery, or talk about those, we say we want to know what this is, because understanding that pathology will dictate a lot of what we do, and the treatments can be vastly different depending on what that pathology is.
Let's start talking a little bit about treatment. You're a surgeon, so is surgery the kind of foremost treatment for most of these kinds of tumors or associated conditions?
So the decision whether surgery becomes the primary or secondary, or at least part of the story that you tell someone, is based on really two different things that I'd like the listeners to think about. If the patient has a tumor that destroys or injures the spinal column in some way, in other words, the bone is broken, surgery sometimes has to be done just to put the spine back together. Just like fixing some kind of broken bone, you might have to have pins or plates to put it back together until it heals. And so sometimes, regardless of the tumor, we just have to fix the broken spine. In the setting of a non-broken spine, even if the patient has some weakness, if the tumor is very sensitive to either chemotherapy or some type of pill or some type of infusion, some type of medicine, or it's very sensitive to radiation, sometimes no surgery is needed. We just treat it with radiation or some type of medicine, and the tumor shrinks and goes away on its own. The issue really becomes, one, is there a structural problem that the surgeon has to fix just because it's broken? And if not, is it the type of tumor that responds to radiation medicine? If so, no surgery. On the other hand, if it doesn't respond to radiation, if there is no good medicine or radiation, then we actually have to cut out that tumor and use surgery as the main means to get the tumor out.
Well, and I guess that goes back to what you were saying before about the need for a biopsy to allow you to make that determination about exactly what kind of tumor at a cellular or microscopic level you're dealing with here.
Oh, it's so important, Ira. And you know, as a provider who's done this for a couple decades and really thought about this, my friends and colleagues across the country, when they say we have a challenging case, I just had this happen yesterday, as a matter of fact, and a friend said, what would you do, he was a surgeon, what would you do for this tumor? And he showed me a picture, and I said, what is it? What does the biopsy show? And he said, oh, I didn't get a biopsy, I just want to know how you do the surgery. And I said, surgery is not even offered until we know what it is. And I had told him that, and he said, oh, so I actually have to do that. Again, just to underline understanding if there is a treatment that's less invasive, more effective, easier for the patient, and giving them those options, that's what I would want as a patient. If you have to use surgery to help me, then go ahead and tell me why. If you don't, maybe I'd like to avoid surgery, and maybe that's the better option. But that's going to be based on understanding what the specimen is on the biopsy, and so this is something we talk about with patients regularly.
And do you routinely consult with other kinds of physicians in the care of these patients?
Absolutely. The name of the game in any type of treatment for a patient really is multidisciplinary, and that's something that I can't understate enough. And the reason is because there's a lot of smart people and a lot of really caring providers out there. When you make a team of smart, caring providers, it's always better. And so an example in these types of lesions is the fact that I just made a comment there might be a medicine to treat that. Well, as a surgeon, I'm not the expert in chemotherapy, so I need to have them involved. If the radiation can be done in a way that's done faster or easier or smoother, I need their input. Now, what often happens is we need both, or we need all three. And so if I'm sitting there saying you should have surgery first, followed by radiation, then chemo, or chemo should happen first, or radiation second, then Dan is going to be the last one to operate, this has to be coordinated. So having a group of oncologists, both surgical oncologists, medical oncologists, and radiation oncologists, along with me, who's a spinal oncologist, is imperative, and it really is the best way it's done. And the patient, in the process, is not just getting multiple opinions on how to treat it, but they're really getting multiple second opinions, because they're, instead of just seeing me and saying I have to see somebody else, they're seeing me and my whole team, which is a group of second opinions, which always makes people feel better that they're meeting me, they're meeting the whole team.
Yeah, let me go back to what you just said, because it's an issue that comes up in the care of tumors elsewhere, cancers elsewhere in the body. This idea of needing more than one modality, meaning you might need surgery and chemotherapy, or might need radiation therapy and chemotherapy. The question of the order in which you do things becomes very important. Can you just speak to what kinds of things help you determine the order in which you do things, assuming that more than one kind of treatment is indicated?
It really is an individual situation. If you were to come in with a strategy and put that on top of all patients, it might work for one patient, but we have to think about this. And so back to the multidisciplinary approach, some of the things that we talked about is, say we're looking at this and all of us are present to look at this case, but the problem that's going on is the patient has a broken back. Their tumor has invaded their spine and broken. Radiation is not going to mend that. It's actually not going to do anything for that. So the patient is going to be having excruciating pain. They might need radiation as part of it, but that's going to be secondary. They're going to say, Dan, please go in and fix the broken back, and then we can always treat with radiation if it's needed later in addition. On the other hand, sometimes there's tumors that we think 90% of the time will melt away with radiation, but we're not completely convinced it's going to be guaranteed for the rest of the patient's life. So we'll sit there and say, we're going to do radiation first, but Dan Sciubba has to be available as a surgeon, and we're going to watch this for the next 5, 10, 15 years, and if it grows back through radiation, Dan will operate then. So this is some of the things that can help us. One last thing that I actually would mention is, for example, say the patient presents with a slow-growing tumor that's been watched for a couple of years by somebody and finally gets to the point where we need to do something about it because we were thinking we could watch it and it did grow or something like that. That's a different type of picture than the person who we never met who presents to the emergency room and can't move their legs. That latter person is someone that I might have to jump on and say, get the tumor out, save their legs, save their spinal cord, and we'll all talk about the next steps as a group next week. And so these are some of the things that change how what steps we go in.
Right. No, I'm glad you brought that up. Obviously, this is not a one-size-fits-all thing. And the idea, not just the kind of tumor you're talking about, but the urgency of the symptoms, the urgency of the clinical situation, obviously is going to drive the clinical decision-making.
Correct.
So let's get back to the surgery part of this a little bit, since that is your bailiwick. When people think of spinal surgery, I suspect they are a little frightened about that and imagine big operations with big scars and lots of hardware and stuff like that. Is your field moving towards the more minimally invasive approach that we hear so much about in other fields of surgery?
Absolutely right. And when people say minimally invasive, I think we all have a sense of what that means. It means trying to make a smaller scar or smaller procedure or less hospital stay. But it changes depending on the field. So let me just talk about that. We have made incisions smaller. We have done procedures that can get more done with less time in the operating room and therefore less time in the hospital. But as I alluded to before, maybe sometimes what we do is in the old days we would, and I mean during my time, it's not, centuries ago, this is during my training and during my early times operating, we would make a very big surgery and say, let's get the whole tumor out, and that would take hours and that would take larger recovery, but that's how we did it. And what we found is that sometimes we can take most of the tumor out and use radiation to get the final part. But just getting most of it out may make the surgery half as big or one-third as big. And it's that last 10% that makes the surgery, another set of hours longer. So the idea of minimally invasive is not just that the scar is smaller or the dissection is smaller or the recovery is less severe, but that by using other toys and other technologies, maybe the surgery has changed. And maybe the goals of the surgery aren't to do everything, but do most of it. And this is, again, that the idea of minimally invasive and multidisciplinary really kind of synergize together.
Oh, that's really interesting. That I hadn't thought of that you're actually not just changing the method of the operation, but you're changing the goals of the operation and allowing it to become less invasive and burdensome to the patient. That's fascinating. Do you ever worry or think about the surgery itself as being a potential hazard in terms of the spread of the tumor? I mean, you are disrupting the tissue there, and is that more than just a theoretical concern?
This is a great question, Ira, and this is something that I've really strongly communicated at our national meetings and with colleagues and with patients alike, and I'm actually really glad that you brought this up. And the reason is because when we think of a tumor that's jumped from, say, the lung to the spine, that behavior of that ecosystem of the body has shown that it's already spread into areas we treat it differently than if it's the primary and only site. And the reason I say is because sometimes we can cure people with certain types of tumors by taking the tumor out completely, but sometimes that means we have to do more work. We have to say, and they'll say, why is the surgery longer? And we say, because we want to get every single cell of that tumor out of your body. And there are some tumors like chordomas, which is a rare tumor, one of these orphan diseases that I treat quite a bit of, and they're not that common. So some surgeons say, hey, I'll do my best and I'll take out 99% of it. Well, if you take out 99% of it and you leave 1%, that will grow into another tumor just as big. And then sometimes I get called saying, hey, Dan, can you take care of this? And I say, oh, we might have missed a golden opportunity to get that out all in one piece, and now we're going to be chasing it a little bit more. Not that there's not opportunities and not that there's no hope, but it's a harder situation. So for chordomas, those are usually sent to people like myself, and I'd rather see them first than having an operation say, hey, we tried our best, because what you just said, those tumors don't have a good treatment with radiation, and they don't have a good treatment with chemo, so it is really surgical, and it's kind of like a root, if you've ever picked weeds, where you pick you snap off the thing, and you say, I feel really good because I don't see the weed anymore, and then it comes back, and maybe it comes back in more places than one. So you have to really, that first time, get the whole thing out. So there is, in some cases, a chance that if you don't think about all the ways to treat this patient, plan some more, that you may regret being a little bit aggressive. And this has to be balanced, like we said, with how quickly they're presenting, with how sick they are, with how worried they are. But these are things that by seeing specialists like us at Northwell who have a great team with us, it's really, really reassuring to patients saying we have thought about as many things as possible so we don't make mistakes like that or don't miss opportunities.
Well, that team approach sounds great, and it sounds like you and your team spend a fair amount of time reviewing the specifics for each individual to make sure that you can come up with a great game plan like that. But let me flip the conversation a little bit and ask you, in your dealings with hundreds of patients like this, what are the biggest concerns or misconceptions even that they bring that you find yourself addressing on a regular basis with patients and their families who are facing these issues?
I think this really cuts to the heart of any one of the listeners out there who are worried about themselves or their family members or friends and saying, hey, this is scary. And so I think the first and foremost thing that I've learned over the years is patients come in with some set of fears that they've had either from their friends or family or from the media. And the ones that I think I've heard the most are, I'm scared about passing away from this condition, of course, and I'm worried about getting paralyzed. And those are real concerns because those are things that anyone would be scared of. The fact of the matter is that we usually have ways to mitigate those overwhelmingly. In other words, those aren't concerns that when we really jump on someone right away, we say, this is an imminent danger. And so what I often do is spend more time not just reassuring about those things if we can reassure those things, which we usually can, but saying, let me tell you more about the reality of what you're going to live like. For example, you're going to take MRI scans for the rest of your life because we always have to see if the tumor comes back. By the way, we have to do x-rays because if we use screws to put your spine together, we have to make sure they're holding up. By the way, that numbness that you had is going to be improved by 90%, but not 100%. And sometimes patients will say, oh, we're talking about such little things. I was worried about paralysis and death. And I say, but trust me, at 2 years out, when I say things have gone well, the things that the patients remind me of say, hey, that numbness near my belly button, is that ever going to go away? And I said, well, this is the one thing that I felt might have stayed, and maybe this is something that you do have to get used to. So my goal in these meetings is what I always say is try to give them the best sense of what their expectations are. And if you can give them that, sometimes it's scary to hear that, saying, hey, this is what I think your expectations are. And they say, oh, I didn't think about all those things. Spend a lot of time talking about it because those are the times that people I think have been the most unhappy or scared when they said, I had no idea this was going to happen. And I said, oh, we didn't talk about that? And that's when they feel like they're more frustrated or more scared. But if you talk about all those things early on, sometimes it's a little overwhelming, and we give them multiple chances to ask more questions, not just one sitting, that when they actually then do see years later, hey, I'm better than you said I would be, Dan. You actually set me up for the worst-case scenario. I said, well, I just wanted to give you an expectation. If you don't do that, they sometimes are confused. And so we spend a lot of time, and I think this is true of any patient, trying to tell them, hey, this is what your expectations are based on my experience, and we're going to keep sharing those with each other so we help you through this journey. And if patients hear that, or they sense that they are together in a journey together, if that journey is 80 years because they're 20 years old, or they're in their 90s and they say, I just want to have a good life for the next 10 years, they really appreciate it and make them feel heard and reassured.
I think that that's such a remarkable explanation of a therapeutic relationship between a physician and a patient. And what I'm hearing is applicable to so many other things besides neurosurgical care of spinal tumors. I mean, it's really the core, I think, of having a good therapeutic relationship with a patient, regardless of the condition, right? Educate the patient about what they have and create a shared expectation about what the future is going to look like and make decisions together about the best way to get there. I mean, to me, that's great doctoring, regardless of the condition.
Yeah, and just to amplify one last thing just to add on is part of this, whether it be spine tumors or neurosurgical care in general, as you said, or any care, is we have to ask the patients what their expectations are and actually what their values are. And so, for example, sometimes patients who have a history of cancer, they will say something like, I care about this most. I care about, as I'm getting my care, whether it be surgery to remove the spine tumor or radiation, that it's close to my house, or that I can do rehab close to my house, or that my family can be present, or that I know exactly what the specimen was and what we're going to do about it. And this is why we have to help each other out in this life as doctors and as patients and as friends. Because if they say to me, this is what I care about, I go, oh, you're totally different than the person who's half your age or your spouse or your child. It is presumptuous for us to assume to treat them differently. So I love hearing that feedback that you gave me because I did not think about this when I first started being a doctor. This is learned by trial and tribulation, and at the end of the day, when you can connect with those people on what their values are, and then I say, oh, by the way, but specifically the spinal tumor, this is what I think, it's a much more satisfying relationship for all involved.
And I think patients feel that. They respond to that, and I think they deeply appreciate that. So in the little time that we have left, I'd like to have you direct our gaze towards the future here. So what's new in this field? What's coming in this field that you'd like to share with us?
So there's a couple things, and we alluded to some of them, but I'll categorize them. So that as we look, all of us, all the entire ecosystem of anyone who cares for or has a spine tumor, what do we look for hope for improving these areas? One is what's happening every day, and people know this, is technology and technical changes. So we're doing smaller incisions. We're using what we have augmented reality. I was actually the first person to use augmented reality in the spine in the world, and we recorded that about a year ago. And so we're using ways to make the surgery safer and faster by using technology, and that is something that this country and others are just so excited about, because we get it. We get if we can see it faster, make it smaller, have nanoparticles or smaller particles or different types of scopes, that's better. And that's happening every day, and we're using it every day. And we have the leading technology here at Northwell Neurosurgery, and so that the issue is that we are trying this on a daily basis and sharing it. The second thing is actually making patients more specific to what they present with. In other words, as we went back to that biopsy, we have to look at these tissues, because a tumor is not a tumor is not a tumor. And so, for example, people might understand breast cancer more than they understand spine tumors, but breast cancer, there's a whole different group of breast cancers, and some of them melt away with medicine, and some of them melt away with radiation. Some need to be operated on. Spine tumors are the same. So we are doing genetic testing and using all the specimens that we get from patients to help them for the next patient. In addition to that, we sometimes put them in animals, and then we treat the animals with different treatments, radiation, surgery, and chemotherapy, and we can infer from back to the patient saying, hey, that one animal did better with this drug that's experimental, and we're going to try that with you now that we know it's safe. And so we're actively using this platform to tell patients, we're not just going to treat you the way your parent was treated, we're treating you the way that we're treated right now. With new technology and genetic. And then finally, I think it's, as we already discussed, and I don't want to repeat it too much, it's about meeting the patient where they are. It's not about the doctor saying, I'm the smartest in the room and I'll tell you what to do. That's very arrogant and very wrong. We have to say to the patient, you don't know much about it, but what matters to you in your life at this time, because any intervention is going to be maybe a trade-off. We're maybe going to have to ask you to hang out in the hospital. We're maybe going to have to ask you to the doctor's appointment. How do you feel about this? And they're going to say, I'm willing to trade that if you give me something back. So I think the three things are technical and technology, genetics and science, and then finally the patient experience. And that's happening with spine tumors, and we've written papers on this and written books on this. And at Northwell Neurosurgery, in our spine tumor multidisciplinary group, we are dedicated to using all three of these to make the next person's experience safer and more satisfying for all involved.
Dan, that sounds great. I think that's a great place for us to end it. So thank you very much for this really enlightening conversation today.
My pleasure, and thank you for having me. This is a great platform, and I'm so delighted I had an opportunity to be with you. Thank you.
My pleasure. So my guest has been Dr. Daniel Sciubba. Dr. Sciubba is the co-director of the Institute for Neurology and Neurosurgery at Northwell Health and chair of the Department of Neurosurgery at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. For more information about this program and to find past episodes, please visit sites.hofstra.edu/wellsaid. You can also subscribe to our free podcast, available on Apple Podcasts, Stitcher, or wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.